to this week's edition of the Research Sofa. I'm here today with Jayati Das-Munshi, who's a psychiatrist and epidemiologist. So great to have you here today, Jay. I wondered if you could just tell us a little bit about the work that you've been doing around the physical health of people with severe mental ill health.
Great, thanks Emily, nice to be on here this afternoon. So as you mentioned, I'm a psychiatrist, and I came into this area when I was working clinically, and I sort of discovered that people with mental health problems really do badly in terms of physical health. And, you know, it's for a range of issues, but some of the issues are around, I suppose, there's a kind of, at that time, it was a while ago, there was a real kind of, you could really feel the kind of lack of parity of esteem in terms of the sort of barriers that people with physical health, with mental health problems experience when trying to access physical health equitably. And so this then drove me to the kind of program of work that that you're asking me about years ago. And I ended up designing a study looking at the physical health of people with severe mental illnesses, but with a focus on ethnic inequalities. So that's the other thing that I'm interested in. And we used very large scale data sets to get at this. And this is because there isn't actually very, at that time, and even now, outside of health records, there isn't really good enough quality data with sufficient numbers to be able to look at these important issues. And there hadn't been much done when trying to understand how the physical health of people varied, for example, by Indian, Pakistani, Bangladeshi, Black Caribbean, Black African ethnicity. And I thought that was quite important because we know that lots of the physical health problems that people with severe mental illnesses experience, like diabetes, are also more prevalent in these groups. So we did some work using large-scale data sets to try and understand that. So looking at things like how common physical health conditions were in those groups, so conditions like diabetes. We also did some work looking at mortality outcomes. So how did people with severe mental illnesses fare in terms of life expectancy and risk of death, and how did that vary if also they were from a minoritized or ethnic minority background. And then we also did some qualitative studies, so some interviews with service users to understand from their perspective. So this was like a program of work that started, about sort of 6 or so years ago. And then of course, COVID happened, and our sort of current focus of work has come onto that a bit more. So, I mean, and I can talk about this in a minute, but we know that COVID-19 has had a sort of double effect. It's really sort of made things worse. We went into the pandemic knowing that people with severe mental illnesses, died 50 to 20 years earlier than the general population. And it really does seem from the evidence that's coming out now that COVID-19 has made things even worse. And of course, ethnic inequalities have been very much interwoven into our concerns about this. So that kind of in a nutshell, why I came into it and the sort of work that we did do and have been doing.
Yeah. Oh, yeah, that all sounds, really interesting and aligns with some of the work that we've been doing around the COVID-19 pandemic and people with severe mental illness, where we've looked at people's experiences of the pandemic. And so I just wondered whether you could tell us a little bit about some of the key findings you found in your work over the last few years.
So relating to COVID or sort of pre-COVID work? So I've got sort of two phases of work that I'm,
Yeah, just generally any key highlights, COVID, pre-COVID, what you think's really important that you'd like, people to know about, really, if that's all right.
Yeah, I think coming into the pandemic, so we finished off quite a few studies, and some of our bigger findings were around showing that people with severe mental illnesses, or confirming really that people with severe mental illnesses die 15 to 20 years earlier than the general population. We did that using data from London, from South London. But what was really marked is we then compared that with sort of the social class gradient. So in the general population, there are real concerns that there is this kind of big gradient in terms of mortality, where people living in the more deprived regions of England die earlier than those living in the more affluent regions. And this is, this has been something that's been a big concern, and some work that showed that this is getting worse over time. And the work that we did showed that people with severe mental illnesses do even worse than those living in the most deprived locations. So it's as if there's a social ladder, and the social ladder is a term that Michael Marmot, Professor Sir Michael Marmot's use when talking about the social gradient. So if there is a social ladder, people with severe mental illnesses fall off the ladder completely. They don't even make it onto the bottom rung. So that just, I think, for me, unfortunately, sort of characterises this area. And we've known this for decades, and it's been very difficult to shift that very big inequality. And then our work looking at ethnic inequalities within this, we found with mortality that there's a similar sort of effect. So if people have a severe mental illness, there's a similar effect on all groups of people from a minority ethnic background as well. And we also did some work looking at comorbidities, and we did some work looking at type 2 diabetes mellitus. So with that work, we found that, and we know that in the general population, diabetes is more common in most of the ethnic minority groups, the main ethnic minority groups in the UK. But in the presence of having a severe mental illness, that risk gets even bigger. And there's almost like an additive effect. So having a severe mental illness puts everyone, even people who are white British, at risk of diabetes, and that's across the board. And then if that person is also from a minority ethnic background, that risk gets even bigger. And just to give you share a statistic with you, which I thought was very marked from that work. So this was done from primary care data covering, I think it was something like 1 million people in East London. So pretty much, because it's primary care, 95% of the population get their care from their GP. So we can sort of say that this is a population survey in a way, but including people with severe mental illnesses. And we found that in people, and I think the cutoff was the older group, 55 plus. So they're not that old, but a bit in the top range. We found that all groups of people with severe mental illnesses had a higher risk of, or higher prevalence of diabetes. But when you looked at the Bangladeshi group, 63% of Bangladeshi people aged 55 or over with a severe mental illness had diabetes. That's almost 2/3 of the sample had diabetes. So as a clinician, that to me really flags up something that we need to be thinking about specifically for those groups. There were high rates as well for the white British group, but it was much lower. It was sort of, and I can't remember the numbers off the top of my head, around about 20%. So you can see that there's a sort of, when we're sort of providing care, we do need to think about the diversity of our populations. And of course, diabetes is a sort of hidden condition that unless you screen for it, you don't necessarily know you've got it. But if you don't manage it properly, then it can lead to all sorts of disabilities like foot problems, eye problems. And then we also know that that has a direct effect on life expectancy. So I think that's kind of a flavour of the work that we did prior to the pandemic. Then when we came into the pandemic, we were sort of, again, as a clinician, we noticed lots of problems actually in terms of access to PPE, testing, things like that, that seem to be having a disparate impact on mental health populations and populations under the care of secondary mental health trusts. So it was a very difficult time in that first wave for everybody, but really that was coming out, I think, just on the ground. And also, I remember going to a meeting where people with lived experience of living with severe mental illnesses at that point in time were talking about the challenges that they faced as well. And it just got us thinking that we needed to kind of repeat the work on people with mental health problems, under the care of secondary care services to see if things had got worse, because unfortunately that's kind of what we suspected. And so we did a piece of work quite rapidly, taking data from a large mental health trust in Southeast London. And actually, before we did the study, I went to a service user advisory group to tell them what I was planning to do. And at that time, it was just to repeat our work, focusing on people with schizophrenia and bipolar affective disorders. But they said to me, well, what about all these other mental health conditions? The people, these other groups of people who are under the care of secondary mental health care trusts, they might also be experiencing inequalities. So we actually then expanded our study to include 9 which range from personality disorders, affective disorders, learning disabilities. We included, of course, schizophrenia and bipolar affective disorders, eating disorders. So we looked across a range of conditions, and we found something quite stark, which is that coming into the pandemic, there was already a heightened risk of death through what's known as standardized mortality ratio. So that was already very much elevated in all of those groups. And then when the first wave of the pandemic happened in 2020, that became even larger, even when you compare to the general population who also experienced an excess risk of deaths. And then we broke it down by cause of death and found that deaths from COVID-19 were very much more elevated across all of the groups. But in fact, the group of people under secondary care with learning disabilities did the worst. And I remember the standardized mortality ratio was something huge. It was sort of 9-fold, risk increase compared with the general population. So very stark findings. And you sort of see that this kind of curve then improves, but after that first wave, but it only improves back to what it was coming into the pandemic, which wasn't great. And we've subsequently got a grant where we've been focusing in on this, and we've been interviewing service users who to understand from their perspective. And we know from, and we're still sort of collecting data and analysing it, but we're already getting indications that there have been so many challenges that people have experienced during the pandemic in terms of trying to access care, which has potentially contributed to things further. So I think this is just an ongoing concern, really. And I think the worry is that it's kind of made things potentially worse, and we're in it still. So we sort of have an added challenge, I think, to be thinking about.
Yeah, I think that's it's similar to the findings that we had around in our smaller scale study, where we conducted a survey of people with severe mental illness over the phone about their experiences of the pandemic and access to services, because we were quite concerned about whether people's access to service would be made more difficult, and that would lead to potential worsening of health inequalities. And so we heard different stories from people about the difficulties they'd experienced, but also thankfully some stories about where people had really gone out their way to try and help people access services and the care they needed. So that we felt that was an encouraging side as well, thankfully, to what's, I think, quite a hard thing to know how to help in some ways. So have you got any thoughts about what next, or what we should be doing to help people?
I mean, I think lots of ideas.
Yeah.
I do think we still have a long way to go in terms of trying to get parity of esteem actually between mental health. And this, we've made actually quite big steps. I think that there have been some changes, and certainly I've noticed this on the ground, clinically, and we know it in terms of guidelines and the different policies that have come out, that where mental and physical health are still are being thought about a bit more together rather than separate. So there's definitely been a shift, but we still have a long way to go. And I think things like the COVID-19 emergency just kind of remind you that when we're in a situation of emergency, mental health does get forgotten and not thought about. And actually, our work, and it sounds like your work as well, Emily, seems to indicate that is a time when we really must be focusing in on these groups even more so, because these are the groups who are going to really get impacted much more than sort of other groups when something like that happens. So I guess there's a lot more to do, and some of this might be trying to somehow, and I don't know how because I'm not a policymaker, but trying to sort of integrate it into thinking at that higher level, so that sort of then has an effect kind of almost structurally, so there's a bit of that to be doing. But I guess at the sort of on the ground, more can be done. And I again, it comes across in our qualitative work. I think it's very hard for people living with multiple conditions to sort of have to access different teams for different bits of their condition. And I think the King's Fund report, there was a report that looked at this some years ago that sort of talked about how people felt like they were, their own care coordinator, having to sort of manage their own, and I think that's actually unacceptable. I feel that, our services are not really integrated enough, and we're still working in silos, and it's in those silos that people fall between, this is the Closing the Gap network, they fall between the gap. It's sort of, how can we better integrate services? And I think it's a big thing, isn't it? But we've done a lot in terms of skilling up, mental health practitioners in terms of physical health. There are various guidelines and, sort of good practice standards that people now follow, and it's now a little bit more embedded in training. And equally, we know in sort of general medical settings, things have got a bit better in terms of thinking about mental health. But it's just really, can we sort of move away from these kind of vertical silos and just somehow bring them together. And I think that would then lead to much better experience for people trying to, access services, but also, for clinicians trying to deliver services. And I do think it's not just about how we work, but it could be around things around how we share information. So we have an opportunity now to kind of, for example, patient care records and the data that gets generated, just making that easier to kind of access as somebody working in the mental health trust, being able to access the GP records of the general medical trust records or whatever, or the other way around. These things can all help. But I think, they're all small steps, aren't they? And, eventually you would hope that we might move to something where things come together a bit better.
Yeah, I think it is just lots of small steps combined to make a big step. And I guess that's what we're trying to do in Closing the Gap, is work with small steps to gradually improve things.
Yeah, absolutely. Absolutely. I mean, I do think also, aside from that, if we can move towards, things that are a bit more integrated. I think the other thing, which I haven't really spoken about, but I think is really big and very tricky and challenging, is the sort of stigma aspect, the sort of diagnostic overshadowing that people, so that the example where somebody's got chest pain or tummy ache and they go into A&E, and the minute they go in, it flags up that they've got schizophrenia, and then they don't get seen for the tummy ache and the chest pain. Instead, they end up being referred to psychiatry. And this is, I think, really, really problematic. And there's countless examples of this. There's really hard evidence that this happens. And there's really, so we know that this is a big issue, and it has an effect. This directly affects, we know, access to, sort of evidence-based care, for example. So I do wonder, a lot of the drivers have been around, how can we better think about clinical guidelines, or how can we prescribe better? But actually, I do think we need to think and try and tackle some of these bigger systemic barriers. And again, it's not something I know a lot about in terms of how do you intervene, but there could be training initiatives. There could be, there could be lots of other ways of trying to kind of ensure that things are a bit more equitable at that level as well. But I think that's a big piece of work. But I think, unfortunately, it still continues to pervade, a lot of this, including what I just described in terms of sort of COVID-19 effects, I think.
Yeah, I think you're right. I think in our smoking work, we found that there's a lot of stigma that's led to things not being perhaps as, helpful as they could be for people.
Yeah, exactly. And it plays out, I think, in terms of their health outcomes. Yeah,
I think so. Is there anything else you'd like to add today before we close?
No, not at all. I think I've it's been very nice to talk to you and just to share with you some of this work, and it sounds like you're doing some great work in this area as well. And it's good to hear that it's all kind of similar, actually.
Yeah.
So no, it's been really nice to speak to you.
Yeah, it's been really nice to speak to you too, and thank you for coming on the Research Sofa today and just telling us about the fantastic work that you've been doing over the last years. So thanks for joining us.
Nice to meet you.
Thank you.